Good morning, everyone. Today I'll be presenting my paper on decoding gastrointestinal clear cell sarcoma, a clinicopathological and molecular study of a rare aggressive neoplasm. So it's a rare aggressive neoplasm with distinct clinicopathological and molecular features. It is also termed as malignant gastrointestinal neuroectodermal tumor. It is characterized by S100 SOX10 immunopositivity along with EWSR1, ATF1 or CREB1 fusion. Despite its recognition as a separate entity, diagnostic challenges still persist, and it is frequently misdiagnosed due to its morphological overlap with melanoma, GIST, and other sarcomas. So the primary aim of the study was to elucidate the key diagnostic criteria, the immunohistochemical profile, molecular findings, and the survival outcome of the patients. It was a retrospective study, and department's archive were searched from year 2015 to 24, and the HE slides, IHC slides, and blocks were retrieved and reviewed, and ancillary studies wherever required were performed. All the clinical imaging details were also collected, and all the histomorphological features were reviewed in conjunction with the clinical data. Follow-up data was also collected regarding survival and recurrence. So the results, a total of 9 cases were identified, which included 3 biopsies and 6 resection specimens. The mean age of the patient was 36.5 years and the median age was 32 years. There were, out of 9 cases, the 5 primary was in colon, 3 presented with small bowel primary and 1 presented with stomach primary. There was a male predominance with 8:1 male to female ratio. The patient presented with all the patients presented with common clinical features of abdominal pain, bowel obstruction, or bleeding per rectum. Metastasis was observed in three of the 9 cases, with the metastatic sites being lung, omentum, and the mesentery. So this is the gross image. As we can see, it's a solid tumor which can ulcerate the mucosa, thus mimicking carcinomas. On histomorphology, the tumor cells are arranged in vague nested architecture, or they can present as pseudo-alveolar pattern. We can see that tumor cells are morphology preserved around the vessels while they are separating away from the vessels. This also shows the pseudo-alveolar pattern. And some of the tumors showed myxoid areas at the interface, thus it can be confused with adenocarcinomas. So on high power view, tumor cells had pale eosinophilic to clear cytoplasm with a vesicular nucleus and inconspicuous in some way dominant nucleoli. And some of the cases, high-grade features were observed, including osteoclastic giant cell and perineural invasion. So immunohistochemistry was performed, and the tumor cells were positive for S100 SOX10 with a high Ki67 labeling index. The markers for melanoma, GIST, and Ewing sarcoma were negative, as proved by IHCs. So we proceeded with EWSR1 break-apart fish, which revealed break-apart signals in more than 90% of the cases, thus indicating EWSR1 gene rearrangement, thereby confirming the diagnosis of gastrointestinal clear cell sarcoma. All the patients underwent surgical resection, 1 received adjuvant radiotherapy, and 3 out of the 5 patients died, while 4 were lost to follow-up. So the key differential diagnosis of GCCS include melanoma, GIST, PCOMA, neuroendocrine tumor, synovial sarcoma, and metastatic clear cell sarcoma of soft parts, with each having a specific characteristic IHC and molecular markers. So coming to discussion, GCCS or malignant GNET represent a diagnostic challenge due to its morphological and IHC overlap with other mesenchymal and neuroectodermal tumors. Our findings reinforce that as S100 SOX10 co-expression in the absence of melanocytic marker is a hallmark of GCCS, thus distinguishing it from metastatic melanoma, which is the primary differential. The consistent EWSR1 rearrangement, which was 100% in the tested cases, further validates its molecular identity, thus contrasting it from other differential that are GIST, PCOMAs, or other tumors. So some cases showed focal SMA and Desmond positivity, which in some cases may mimic myogenic tumors. Thus, the necessity of molecular testing is necessary. In these ambiguous cases, the tumor has poor survival outcomes with a median progression-free survival period of 14 months, thus highlighting the tumor's aggressive biology and resistant to conventional therapies. The predominance of colonic involvement in metastatic cases in our series suggests its site-specific biological behavior, as larger cohorts are needed to confirm this trend. So to conclude my presentation, this study delineates the clinicopathological and molecular spectrum of gastrointestinal clear cell sarcomas. The integration of molecular diagnostics along with traditional pathology is crucial for diagnosing this tumor. And future efforts should prioritize targeted therapies against GREB-ATFN pathway and routine adoption of standardized FISH protocol to further improve the diagnostic accuracy and therapeutic outcome. Thank you.